I am only an ICU doctor, and I am interested in everything going on in the intensive care unit. I'm also president of this World Federation of Societies of Intensive and Critical Care Medicine, and that's how, by international collaboration, we can obtain data from all over the world. And I will present to you some very new data, unpublished, unpresented before, I think, on the renal aspects of the ICON study. The ICON study, whose main results were published in the Lancet Respiratory Medicine 2 years ago, was a very large global study entering data from patients admitted to intensive care units all over the world. But the data were collected not just on admission, not just during the first days, but throughout the ICU stay, and the hospital outcome was also recorded. And there were many variables recorded, so it's a huge database of ICU patients, except those admitted for postoperative surveillance. We wanted to focus on critically ill patients. And it was a fantastic response, with more than 10,000 patients hospitalized in 730 ICUs in 84 countries. And India, the UK, Germany were the countries most widely represented. But if you are from Italy, you can be proud of seeing that Italy was actually number 11 with 300 patients enrolled. Number 11 out of, once again, 84 countries, with even at the end Afghanistan, Honduras, and Turks and Caicos Islands. So it was a very international database with a good mixture of academic institutions and more peripheral hospitals. I remind you that today the ICU mortality rate is somewhere around 16%, again excluding surveillance, speaking only about critically ill patients. And hospital mortality rates of these patients are at around 22%. Now, it may vary somewhat around the globe, but not so much, actually. Please, in this slide and in the following ones, keep in mind that there are not many data from Africa, of course. From Africa, it's primarily the north of Africa and South Africa. But you can appreciate here that the mean age of our patients now is somewhere between 60 and 65 years. Hospital length of stay are usually around 10 to 14 days. So we could speak about international differences, but this is not really the main focus of my presentation today. I'd like just to point out, especially for those of you who do not work in the intensive care unit, that in the ICU, renal dysfunction is just one organ dysfunction, and it's rarely isolated. This is the number of patients with sopharenal on admission of 0, 1, 2, 3, 4. You can see that actually there are more patients in blue with a renal score of 4, with established renal failure since admission, than 2 or 3. And you can see that the mortality rate increases, of course, but up to SOFA score of 3. 3, 4, it's about the same mortality rates. So you asked me to focus on sepsis, and clearly in sepsis in particular, it's very difficult to find out what the cause of renal dysfunction is. It could be hemodynamic alterations, shock. It could be hypovolemia associated with that. It could be some nephrotoxic toxic agents, and of course, behind all this, there is an inflammatory response with many inflammatory mediators. So keep in mind that altered renal function to us is one of the 6 organs that could be altered. And it's intimately related to multiple organ failure and sepsis. That's how to keep an eye on all organs. We like to use this kind of scores. Of course, for the renal aspect, it's a combination of creatinine and urine output. 0 would mean normal creatinine, no problem with urine output, and failure would be a creatinine above 3.5 and or some form of oliguria. So you could even look at total SOFA score, reflecting the degree of multiple organ failure, and then you can see the number of patients in blue. That's the blue line. There are not many patients having almost no organ dysfunction, and there are, of course, less patients with very severe organ dysfunction, but the mortality rate, of course, goes up very progressively over this range of initial SOFA scores. So this is the mortality for the various organ systems, just to show that if there is a single renal dysfunction, the mortality rate is 7%? 7%. So it's when you look at multiple organ dysfunction, and of course, that's the vast majority of patients that you see the mortality rates going up substantially. And as we know, it's not just a snapshot that we must take into account, but clearly the time course. And when you see an increase in any form of organ dysfunction, the mortality rates go up substantially, as represented in red on this slide. But also, very importantly, when the degree of organ dysfunction remains unchanged in yellow-orange, the mortality rate is still relatively high. What we want to see is an improvement in each organ function. That's associated with lower mortality rates. So in the ICON database, 13% of patients received renal replacement at some point during their ICU stay. It's about the same number of hemodialysis, hemofiltration, but of course, some patients received both, usually hemofiltration first and hemodialysis next. Perhaps it's a bit higher than before. Clearly, the use of renal replacement therapy is not going down, that's for sure. In the SOAP database, which was a European database, but using exactly the same methodology, we found that 10% of the patients were treated with renal replacement therapy. And here there was a majority of hemofiltration. Hemofiltration was used more than hemodialysis, but this is, of course, related to international variation. In Europe, people would use hemofiltration more commonly than hemodialysis, and this is even more the case in Australasia. But you can see that there is some international variation in the selection of the technique. But the number of patients requiring renal replacement therapy does not vary so much. Although, as expressed by the previous speakers, yes, there is some difference according to the country's income. It's clear that in low and lower middle income countries, renal replacement therapy is used less commonly than in upper income countries. Interestingly, there are some ethical aspects, as already alluded to, and if we look, and that's another study that I will not present in detail, of course, but if we look at decisions to limit life support therapies, as you can see, during the ICU stay, it's often the need for renal support therapies that will come into play to decide to stop. Now, your old father has renal dysfunction in addition to all the rest, and we would have to start hemofiltration or dialysis. Oh, no, now it's too much. No, not another machine. And that's actually a relatively common reason to give up and not starting these additional techniques. So focusing more on the kidney in sepsis, once again, we know that the pathophysiologic alterations are complex and multiple, associating some hemodynamic and inflammatory alterations. Already in the SOFA study that I alluded to in our European study, we found that in patients with renal failure, infection was much more common than in patients without renal failure. And also looking at outcomes, when we look at SOFA renal of 3 or 4, renal failure, sepsis on admission was found in 43% of the patients, whereas with the maximum renal score was 0, 1, or 2, only 28% of patients had sepsis. So now let's focus on the very new data from the ICON study. So we have enough data on creatinine and urine output in now 9,579 patients. Well, we can consider separately the 912 patients having a chronic renal failure to focus on the rest of the cohort. Before I go further, I'd like to mention that Dr. Peters and Dr. Pickers from the Netherlands should be recognized because they will be leading authors on the paper. They wrote the paper on behalf of the group. So 30% of the patients had sepsis, and you can see that indeed acute kidney injury was much more common in these patients than in patients without sepsis. All these differences being highly significant in view of the large number of patients. And also in sepsis, acute kidney injury was more severe, with 21% of patients requiring renal replacement therapy versus only 5% in the non-septic subgroup. Again, the average was about 13%, but you can see here the major differences depending on the presence of sepsis or not. And so this is a slide representing the severity in further detail on each subgroup from failure, injury, and the two others. You can see that when you look at sepsis above non-sepsis, you can see that the severity of renal dysfunction was greater in septic patients than in non-septic patients. Now, interestingly, development of AKI after ICU admission, that was actually more common in the absence of sepsis than in the presence of sepsis, probably because in the presence of sepsis, you get it earlier. You get it right away. Whereas in other diseases and trauma, heart failure, etc., it may come later. But interestingly, in the moderate forms of acute kidney injury, there was a greater degree of improvement in sepsis than in non-sepsis. The difference is again being statistically significant. However, when there was clearly failure, then the septic patients had less chances of recovering a better renal function. So if we look at mortality, acute kidney injury with sepsis, mortality rate of 33%. But you know, acute kidney injury without sepsis, look at the mortality rate. It's not increased. And if you look at now renal replacement therapy, yes or no, if I continue at the right side of the graph, even in the absence of renal replacement therapy, the mortality rate is not very much increased when there is acute kidney injury in the absence of sepsis. However, if there is a need for renal replacement therapy, it gets to 31%. Actually, the same mortality rate as in septic patients not requiring renal replacement therapy. But if a septic patient needs renal replacement therapy, then the mortality reaches about 50%. very high. Now, what about the patients with chronic renal failure? Well, if we look at the absence of sepsis, they stayed for 16 days. 32% of them needed renal replacement therapy. Hospital mortality was 26%. But when they developed sepsis, the length of stay, wow, increased to 55 days. Renal replacement therapy in the majority of patients, and hospital mortality was 44%. So, actually, it's interesting. When we looked at independent association between renal failure and in hospital mortality, it increased it in non-septic patients and in septic patients to the same extent. To the same extent. So by itself, acute renal, and again, there were many data in the databases. It's not just an Apache score and age and medical or surgical. No. It's a huge database, and you can see that the differences are the same whether or not there is sepsis. And this is actually the graphical representation. The hazard ratios were adjusted for age, sex, non-renal Apache 2 score, renal replacement therapy on admission, inotropic score, reason for admission, and type of admission. And you can see that, indeed, renal failure is, by itself, associated with a higher mortality rate, but the increment in mortality rate is the same whether there is sepsis or not. So, mortality rate in sepsis and non-sepsis. In sepsis, and in non-sepsis, you can see that in the ICU, whether you are in the R classification or you have no AKI, there is no big difference in mortality rate. It goes up when you go in I and F stages of renal failure. And if I add the chronic renal failure, these patients lie somewhere in between I and F. And this is the graphical representation. As expected, the mortality rate over time goes down as renal failure as the degree of renal dysfunction is becoming more and more severe, and you can see chronic renal failure being close to acute failure. So in conclusion, there are a number of data there, but if we want to summarize them in one sentence, it would be that septic AKI is more frequent, more severe, and associated with higher mortality rates than non-septic AKI. And sepsis patients with less severity AKI are more likely, but those with failure are less likely to recover renal function than non-septic patients. Grazie mille.